In this module, we will explore the history of EMS. Once completed with this module, you should be able to describe key historical events that influenced the national development of EMS systems. To begin our exploration of EMS history, we will start with the period of time prior to World War I. Many advances in emergency medicine evolved out of the need to treat wounded soldiers, and many historians recognize the work of the Knights of St. John during the 11th century Crusades as some of the first emergency responders in an EMS sense, given their work in providing first aid to soldiers on the battlefield and taking them to treatment tents located nearby. Over a period of 4 months, Catholic monarchs laid siege to the Spanish city of Malaga, eventually wresting control of the city from the Muslims who held it prior. The conflict is significant for EMS, as it is the first such event where wounded soldiers were moved from the front lines to medical tents via the use of bedded wagons. These wagons served as the period's equivalent to an ambulance for the transport of the injured. The catch, however, was that the wounded soldiers had to wait until the battle was over before the wagons would venture onto the battlefield to collect and transport the wounded. A few centuries later, Napoleon employed the use of wagons on the battleground to aid in the treatment of fallen soldiers, and his chief physician, Dominique Jean-Larrey, arranged for wounded soldiers to be picked up from an active battlefield. Fast forward half a century or so to the American Civil War, and the United States Surgeon General William Hammond enters the discussion. Under his leadership, the military created a medical corps whereby litter bearers and ambulance wagon drivers were responsible for transporting wounded soldiers from the battlefield to Army hospitals. Shortly thereafter, in 1865, the first civilian ambulance started operation at Commercial Hospital in Cincinnati, Ohio. In 1869, Bellevue Hospital in New York City started an actual ambulance service with wagons and horse teams. The service responded to just over 1,400 runs in their first full year of operation in 1870. In keeping with updated technology, it was only a matter of time before horse-drawn carriages were replaced by mechanical vehicles, and the first motor-powered ambulance went in service at the Michael Reese Hospital in Chicago, Illinois in 1899. Within the period of time from World War I through World War II, EMS saw incremental improvements in terms of its availability to the public as well as how it was provided. Evidence of emergency care from World War I led to the introduction of traction splints for femur fractures, which often saved patients from having to undergo an amputation of the affected extremity. Telegraph and telephones were being used to contact police departments, which could then dispatch an ambulance. Communications were also improving, and many ambulances began utilizing two-way radios. During this period of time, we began seeing ambulance services provided by entities other than hospitals. Prior to World War I, ambulance services were predominantly hospital-based. In 1926, the Phoenix Fire Department began providing inhalator services to the community, which marked the fire service's entrance into the realm of EMS. Just 2 years later, in 1928, Julian Stanley Wise founded the first volunteer rescue squad in the country, the Roanoke Life Saving and First Aid Crew. Once World War II was in full swing, many hospitals could not continue providing ambulance services as they once did because doctors were in short supply due to the war effort, and many were being drafted into service. To fill this void, many municipalities began utilizing their police and fire departments for providing EMS. With that being said, there were no uniform training standards or education available, so the quality of care provided varied significantly from agency to agency. In some agencies, fire departments in particular, being an ambulance attendant was considered to be a form of punishment. It was not a desired position. Ultimately, the vestiges of modern EMS really started to blossom after World War II. Helicopters were used extensively in the Korean War to transport over 18,000 wounded soldiers. Mouth-to-mouth resuscitation was developed in 1956, and the first portable defibrillator was developed at Johns Hopkins Hospital in 1959. In 1960, the Los Angeles Fire Department began incorporating medically trained personnel on its engine, ladder, and rescue companies. Let's pull away from our timeline for just a moment and look at the impact that military conflicts have had on emergency medicine. Given that EMS was historically driven by advancements out of the military, one can see a distinct decrease in injury mortality rates from the Civil War through modern times. While different resources may fluctuate somewhat on the numbers, and data can also look at the incidence of disease versus actual injuries, the nature of the injury, and other factors in various mortality rate studies, mortality rates of 1 out of every 8 soldiers wounded in battle during the Civil War appear commonplace in the literature, resulting in a 14.3% mortality rate. In World War I, this number was reduced to 8.5%. The advent of helicopters for medical evacuation yielded even greater reductions in battlefield mortality within the Korean and Vietnam Wars, with rates of 2.4% and 2.6% respectively. In the modern day, the mortality rate has climbed from the rates recorded in Korea and Vietnam, but that is often attributed to the lethality of the weapons employed in the modern theater of war, in conjunction with more selective and hazardous missions and other factors. Arguably, this decrease in battlefield mortality rates are strongly correlated with the ability of the military to evacuate wounded soldiers to definitive medical care. In the early years of the Civil War, soldiers had to self-evacuate the battlefield and walk to the nearest hospital, which could be dozens of miles away. The time frame associated with the delay in definitive medical treatment from the occurrence of a soldier's injury was 12 to 15 hours in World War II. In Vietnam, that time had been reduced to approximately 2 hours. In the recent Middle East military activities in Iraq and Afghanistan, that time was reduced even further to somewhere between 30 to 90 minutes. While we have focused predominantly on military data thus far, that focus began to shift in the mid-1960s when the National Academy of Sciences published Accidental Death and Disability, the Neglected Disease of Modern Society. Referred to simply as the White Paper, this document is often referred to as a watershed publication in that it was responsible for starting civilian EMS in the United States. For the first time at a national level, we started looking at accidental civilian deaths and injuries and asked ourselves what could be done to change some rather disheartening trends. In just 1965 alone, the document stated there were 52 million accidental injuries in which 107,000 people were killed, more than 10 million were disabled, and 400,000 were permanently impaired, all at a cost of $18 billion, or the equivalent of over $142 billion in 2018. The White Paper also called attention to several systemic challenges within the United States at the time. There were no uniform laws and standards governing EMS. Ambulances and the equipment within them were of poor quality. Communications between EMS and the hospitals to which they were transporting were lacking or inadequate. Emergency medical personnel did not receive proper training, and hospitals routinely staffed emergency departments with part-time personnel. At this time, the United States was knee-deep in the Vietnam conflict, and the data showed that more people died in automobile accidents in one year, 49,000 in 1965 alone, than had been killed in the Vietnam conflict up to that time. In totality, the Defense Casualty Analysis System records the number of U.S. military fatal casualties in the Vietnam conflict as 58,220. Given that the conflict in Vietnam would wage for another 10 years after the publishing of the White Paper, the comparison between the two helped underscore the scope of the injury problem within the United States. Within the same time frame as the publishing of the White Paper, Congress passed the National Traffic and Motor Vehicle Safety Act and the Highway Safety Act in September of 1966. The laws provided the federal government with the means to set and administer new safety standards for motor vehicles and road traffic safety, while also creating the National Highway Safety Agency, which is now known as the National Highway Traffic Safety Administration. As far as EMS is concerned, the laws required states to have a highway safety program designed to reduce traffic accidents and deaths, injuries, and property damage resulting therefrom. These programs had to comply with uniform standards promulgated by the Secretary of Commerce, which included, among other things, emergency services. The law also empowered the Secretary of Commerce to make funds available to states and local agencies for training or education of highway safety personnel, while also allowing for the funding of research fellowships in highway safety and emergency service plans. The total appropriation of funds within the law was $322 million over 3 years from 1967 through 1969. In case you were wondering, many resources lump these two laws together as a single act, but they were indeed two separate acts passed on the same day. Additionally, many associate the creation of the United States Department of Transportation with these acts, but that is not actually the case. It was approximately a month later that Congress passed the Department of Transportation Act, Public Law 89-670, which created the DOT and moved the responsibilities associated with the National Traffic and Motor Vehicle Safety Act from the Department of Commerce to the newly created Department of Transportation. Ultimately, this law had a significant impact on the development of EMS within the United States, especially given the requirement that states include emergency services in their highway safety programs. The funding made available to train and educate highway safety personnel was helpful as well. While motor vehicle accidents are only one type of emergency to which modern EMS agencies respond, preventing and mitigating highway deaths and injuries were the impetus behind the federal funding that laid the foundation for EMS within the United States. Shortly after the passage of the National Traffic and Motor Vehicle Safety Act, the Highway Safety Act, and the Department of Transportation Act in 1966, the DOT published its uniform guidelines for state highway safety programs. While all 13 guidelines are included on this slide, the most important guideline to EMS was the 11th, which called for state health departments to employ a full-time person to work on emergency care of accident victims, while also requiring the establishment of a statewide emergency medical services program. These guidelines included several categories and subsequent recommendations. Under the regulation and policy category, states were directed to establish the EMS program and designate a lead agency, outline the lead agency's basic responsibilities, including licensure and certification, require comprehensive planning and coordination, designate EMS and trauma system funding sources, require data collection and evaluation, provide authority to establish minimum standards and identify penalties for noncompliance, and provide for an injury trauma prevention and public education program. Where resource management is concerned, the lead agency in each state should maintain a coordinated response and ensure that resources are used appropriately throughout the state, provide equal access to basic emergency care for all victims of medical or traumatic emergencies, provide adequate triage and transport of all victims by appropriately certified personnel, at a minimum trained to the basic EMT level, in a properly licensed, equipped, and maintained ambulance, provide transport to a facility that is appropriately equipped, staffed, and ready to administer to the needs of the patient, and appoint an advisory council to provide a forum for cooperative action and maximum use of resources. As far as these categories are concerned, human resources and training is really where the proverbial rubber hits the road in EMS, as police, fire, EMTs, paramedics, dispatchers, physicians, nurses, hospital administrators, emergency managers, and others are all recognized as crucial individuals within the EMS system. As such, states should provide a comprehensive statewide plan for stable and consistent EMS training programs with effective local and regional support. Additional standards mandate that the state ensure sufficient availability of adequately trained EMS personnel. Establish EMT Basic as the state minimum level of training for all transporting EMS personnel. Routinely monitor training programs to ensure uniformity and quality control. Use standardized curricula throughout the state. Ensure availability of continuing education programs. Require instructors to meet state requirements. Develop and enforce certification criteria for first responders and pre-hospital providers. And require EMS operating organizations to collect data to evaluate emergency care in terms of the frequency, category, and severity of conditions treated and the appropriateness of care provided. Transportation is also of critical importance to EMS, and states should require safe and reliable ambulance transportation by developing statewide transportation plans, including the identification of specific service areas. Additional suggestions include implementing regulations that provide for the systematic delivery of patients to appropriate facilities, developing routine, standardized methods for inspection and licensing of all emergency medical transport vehicles, establishing a minimum number of providers at the desired level of certification on each response, coordinating all emergency transports within the EMS system, including private, public, or specialty transport, and developing regulations to ensure ambulance providers are properly trained and licensed. To reduce mortality and morbidity rates, seriously injured patients must be delivered to the closest appropriate facility in a timely manner. As such, states should ensure that both stabilization and definitive care needs of the patient are considered. The determination is free from non-medical considerations, and the capabilities of the facilities are clearly understood by pre-hospital personnel. Hospital resource capabilities are known in advance so that appropriate primary and secondary transport decisions can be made, and agreements are made between facilities to ensure that patients receive treatment at the closest, most appropriate facility, including facilities in other states or counties. An effective and reliable communication system provides the means by which emergency resources can be accessed, mobilized, managed, and coordinated. Therefore, states should require the EMS communication system to begin with the Universal System Access Number 911. Strive for quick implementation of enhanced 911 services that make possible, among other features, the automatic identification of the caller's physical location. Provide for prioritized dispatch from dispatch to ambulance, ambulance to ambulance, ambulance to hospital, and hospital to hospital. Ensure that the receiving facility is ready and able to accept the patient, and provide for dispatcher training and certification standards. Being as how traumatic injuries and deaths provided the impetus for the Highway Safety Act, it should come as no surprise that the DOT standards included several trauma-related provisions, such as the need for states to maintain a fully functional trauma system to provide high-quality, effective patient care by including trauma center designations, using the American College of Surgeons Committee on Trauma guidelines as a minimum, triage and transfer standards for trauma patients, data collection and trauma registry definitions for quality assurance, mandatory autopsies to determine preventable deaths, and systems management and quality assurance. Public awareness and education about the EMS system was recognized as being essential to maintaining a high-quality EMS system, and each state was encouraged to implement a public information and education plan to address the components and capabilities of an EMS system, the public's role in the system, the public's ability to access the system, what to do in an emergency, which would include bystander first aid training, education on prevention issues such as alcohol or drug use and abuse, vehicle occupant protection, speeding, motorcycle safety, and bicycle safety, the EMS provider's role in injury prevention and control, and the need for dedicated staff and resources for public information and education programming. EMS is a medical care system in which physicians delegate responsibilities to non-physician providers who manage patient care outside the traditional confines of the office or hospital. As a result, physician involvement in all aspects of the patient care system is critical for effective EMS operations, and states should require physicians to be involved in all aspects of the patient care system, including planning and protocols, online and offline medical direction and consultation, and audit and evaluation of patient care. The last EMS element defined within the Highway Safety Program's Guideline Number 11 was the evaluation of the EMS system. To assess and improve a statewide EMS system managers should evaluate the effectiveness of services provided to victims of medical or trauma-related emergencies, define the impact of patient care on the system, evaluate resource utilization, scope of service, patient outcome, and effectiveness of operational policies, procedures, and protocols. Develop a data gathering mechanism that provides for the linkage of data from different data sources through the use of common data elements, and evaluate both process and impact measures on injury prevention as well as public information and education programs. Needless to say, the blueprint for modern EMS was incorporated within those standards published all the way back in 1967. Within that same period of time, the inventor of the portable defibrillator, cardiologist Dr. Frank Pantridge, began something known as the Pantridge Plan by equipping ambulances in Belfast, Ireland with his invention of a 70-kilogram portable defibrillator that operated from car batteries. Believe it or not, this pre-hospital coronary care unit was copied within the United States and was actually credited with assisting United States President Lyndon Johnson when he suffered a heart attack while on a visit to Virginia in 1972. Given the impact of his efforts, Dr. Pantridge has often been called the father of emergency medicine, and we now take the science behind defibrillators for granted. With the white paper as a catalyst, changes began occurring rapidly within the world of EMS. In 1967, Dr. Eugene Nagel worked with the Miami Fire Department to implement the nation's first recognized paramedic program, with paramedics routinely transmitting ECGs to Jackson Memorial Hospital by March of that year. Other paramedic programs were also starting at the same time or shortly thereafter in larger metropolitan areas such as Los Angeles, California, and Seattle, Washington. In 1968, the National Research Council published the book Training of Ambulance Personnel and Others Responsible for Emergency Care of the Sick and Injured at the Scene and During Transport. For those interested, the book is available for free via download through the National Academy's Press. The book was a mere 29 pages in length, with several pages dedicated to introductory information and end-of-text references. By comparison, some current EMT textbooks can exceed well over 1,500 pages. Also in 1968, given some insistence from the FCC, the American Telephone and Telegraph Company, now simply known as AT&T, established 911 as the phone number that would be used to contact emergency services throughout the United States. The number was chosen because it was brief, easily remembered, could be dialed quickly, and was unique in that 911 had never been used previously as an office, area, or service code. As reported by the National Emergency Number Association, only about 17% of the United States population was served by 911 by the end of 1976. This percentage increased to about 26% by the end of 1979. It wasn't until 1987 that approximately half of the country's population had access to 911 emergency service numbers. As of the current day, approximately 96% of the geographic United States is covered by some type of 911 service. In 1970, the National Academy of Sciences published the document Medical Requirements for Ambulance Design and Equipment to help define standards for ambulance design along with required equipment and supplies. The 25-page document is still available online through the Education Resource Center maintained by the Institute of Education Sciences within the U.S. Department of Education. The National Registry of Emergency Medical Technicians was also started in 1970, and the Highway Safety Act of 1970 created the National Highway Traffic Safety Administration, replacing the previously existing National Highway Safety Bureau. In 1971, the American Academy of Orthopedic Surgeons published the first edition of its long-running textbook, Emergency Care and Transportation of the Sick and Injured, which is currently offered in its 11th edition at the time this presentation was produced. This marked the availability of the first textbook for EMS personnel. For clarification, some resources state that this textbook was made available in 1967, but the AAOS states on its own website that the text was first published in 1971. Additional resources have indicated that work on the textbook began in 1967, which would explain the discrepancy in the dates. In that same year, 1971, the AAOS also hosted a national workshop on the training of emergency medical technicians in an attempt to consolidate a lot of the work that had been completed previously at the national level. The culmination of efforts at this workshop resulted in the 1972 NHTSA document, Recommendations and Conclusions for an Approach to an Urgent Problem, which included 12 recommendations for standardizing and improving EMS education. Believe it or not, EMS even garnered recognition within President Nixon's State of the Union address, in which the Department of Health, Education, and Welfare was directed to develop new ways to organize emergency medical services within the country. This resulted in the Department of Health, Education, and Welfare awarding $8.5 million in contracts for the development of model EMS systems. We also saw the start of the nation's first civilian-based air medical transport program in 1972. Flight for Life was founded by St. Anthony Hospital in Denver, Colorado, and is still in operation today, providing regional air medical and critical care transport to 9 states in the Rocky Mountain region. The television show Emergency also started its 8-year run in 1972. For those laypersons unfamiliar with emergency medicine, the television show did a great job of introducing them to the profession and ultimately served as the impetus for many kids growing up in that decade to pursue careers in EMS and the fire service. Very early on, the Department of Transportation recognized that it would be important for EMS systems, agencies, and providers to be readily and distinctively identified for the benefit of both the public at large as well as the patients served by EMS. To meet this need, the DOT adopted and registered the Star of Life symbol in 1972. Each bar on the Star of Life represents one of the 6 functions of EMS: detection, reporting, response, on-scene care, care in transit, and transfer to definitive care. The serpent and staff constitute the staff of Asclepius, which represents medicine and healing. Asclepius was the Greek god of medicine, and the skin-shedding serpent, representing renewal, also has biblical significance given Moses had crafted a bronze serpent mounted on a pole to heal people who were bitten by a serpent. Over the years, the Star of Life has become associated with emergency medical care around the globe and is routinely used to identify EMS agencies, providers, systems, and other related materials. A huge boost to EMS arrived in November of 1973 through the passage of the Emergency Medical Services Systems Act, Public Law 93-154. This law created an interagency committee on EMS while also making $185 million in federal money available over the course of 3 years to support several key initiatives related to EMS. The first initiative was to support projects that study the feasibility of establishing, through expansion or improvement of existing services or otherwise, and operating an EMS system, and planning the establishment and operation of such a system. The second area of focus was to support the establishment and initial operation of emergency medical services systems with an emphasis on the coordination of statewide systems. Funds under this provision could also be used for the modernization of facilities as well as other costs associated with establishment and initial operation. The third topic of emphasis was research related to EMS techniques, methods, devices, and delivery. Lastly, funding was also provided to schools of medicine, dentistry, osteopathy, nursing, allied health disciplines, and other appropriate educational entities to assist in meeting the cost of training programs in the techniques and methods of providing EMS. Needless to say, these funds went a long way in helping states establish or improve their own EMS systems. In addition to securing funding for the activities defined in the previous slide, the EMS Systems Act of 1973 also included a list of 15 EMS system requirements. As defined within the law, EMS systems shall have or perform the following: include an adequate number of health professions and personnel with appropriate training and experience. Provide appropriate training, including clinical training and continuing education programs that are coordinated with other similar programs in the system service area, and emphasize recruitment of veterans with healthcare experience and others with public safety experience to teach such offerings. Join the personnel, facilities, and equipment of the system by a central communication system that uses emergency medical screening, provides access through 911, and allows direct communication connections and interconnections with the system's personnel, facilities, and equipment, along with those of other systems. Ensure there are adequate numbers of ground, air, water, and other vehicles to meet the needs of the system service area that meet location, design, performance, and equipment standards, while also providing trained and experienced operators for those vehicles. Include an adequate number of easily accessible emergency medical services facilities that are collectively capable of providing services on a continuous basis, can be coordinated with other healthcare facilities within the system, and meet appropriate standards relating to capacity, location, personnel, and equipment. Provide access, including appropriate transportation, to specialized critical medical care units in the system service area, or can arrange access to such units in neighboring areas if feasible. Provide for the effective utilization of the appropriate personnel, facilities, and equipment of each public safety agency providing emergency services in the system service area. Have an organizational structure that allows laypersons in the community an adequate opportunity to participate in the making of policy for the system. Provide medical services to all patients requiring such service, regardless of whether the patient has the financial resources to pay for them. Provide for the transfer of patients to facilities and programs that offer follow-up care and rehabilitation as necessary to effect the maximum recovery of the patient. Maintain a standardized patient record-keeping system that covers the patient's treatment from initial entry into the system through discharge while being consistent with ensuing records used in the patient's follow-up care and rehabilitation. Provide public education and information programs that stress the general dissemination of information regarding appropriate methods of medical self-help and first aid, including the availability of first aid training programs in the services area. Provide for periodic, comprehensive, and independent review and evaluation of the extent and quality of the emergency healthcare services provided in the system service area. Maintain a plan to ensure the system can continue to function in the case of a mass casualty, natural disaster, or a national emergency. Lastly, support reciprocal service arrangements with neighboring areas when such services would be more appropriate and effective in terms of the services available, time, and distance. Subsequent to the passing of the EMS Systems Act of 1973, the Federal Department of Health, Education, and Welfare drafted Part 56A to Title 42 of the Code of Federal Regulations governing grants for emergency medical services systems. On July 1, 1974, the regulations went into effect. An important thing to note is that this regulation incorporated the newly developed, as of January 1974, General Services Administration, KKA 1822 ambulance standards into the definition of a ground vehicle for transporting patients. Following the adoption of these regulations, the Federal Department of Health, Education, and Welfare also published the EMS Systems Program Guidelines document in 1975 to assist applicants for contracts and grants funding under the law in understanding the legislation, regulations, guidelines, and related administrative procedures. This document further clarified the 15 requirements of an EMS system as defined within the EMS Act. To evaluate the effectiveness of federal grant funding related to EMS, NHTSA studied highway traffic safety performance nationwide over a period of 6 years and published its statewide Highway Safety Program Assessment in 1975. As far as EMS was concerned, there were some interesting findings. EMS responses increased in the sample area from 8.8 million to 12.2 million from 1969 to 1974, but the number of EMS agencies declined from 18,000 to 16,900. This decline was attributed to funeral homes discontinuing EMS activities. Volunteer fire and rescue groups grew to account for 50% of total services providing EMS. The DOT had produced and offered an 81-hour basic care course that was supported through the grant funding, but only half of the EMTs had received this updated training. In 1975, the American Medical Association's Section Council in Emergency Medicine, which was formed provisionally in 1973, became permanent. The American Board of Emergency Medicine was incorporated in 1976, and emergency medicine was finally recognized as a specialty by the American Board of Medical Specialties in 1979, 11 years after the creation of the American College of Emergency Physicians, 7 years after emergency medicine had been recognized as a specialty by the American Medical Association. The National Association of EMTs was formed in 1975, and NHTSA also produced a curriculum guide to provide a description of the curriculum at a level of detail sufficient for most program planning purposes, short of actually teaching the recommended contents. At the same time, the University of Pittsburgh and Nancy Caroline, MD, were awarded a contract to produce the first EMT Paramedic National Standard Curriculum, which was subsequently published by NHTSA 2 years later in 1977. In 1979, the educational functions associated with the Department of Health, Education, and Welfare were transitioned over to the newly formed Department of Education under the Department of Education Organization Act of 1979. The name of the department was also updated in the Act to the Department of Health and Human Services. At the start of the 1980s, the federal government passed the Omnibus Budget Reconciliation Act of 1981. This legislation enacted sweeping changes related to financial policy within the United States to reconcile the 1982 fiscal year federal budget. These changes impacted numerous industries and topics such as agriculture, banking, education, human services, energy, transportation, Medicare and Medicaid, public assistance programs, and others. As far as EMS was concerned, the Omnibus Budget Reconciliation Act of 1981 eliminated the EMS Systems Act's categorical federal funding to states and replaced it with block grants for preventative health and health services. The practical effect of this funding change was that primary responsibility for EMS development and maintenance shifted from the federal level to the states. States essentially had the ability to take their grant funds and apply them however they saw fit, with EMS being just one part of the larger picture. As a result, total funding for EMS decreased significantly, as reported by the U.S. Congress Office of Technology Assessment in 1989. As the block grants were no longer tied to specific EMS-related criteria as they were under the 1973 EMS Systems Act, states began developing and modifying their own systems apart from each other, which resulted in significant diversity in EMS systems from state to state that still exist today. In October 1984, the Preventative Health Amendments Act of 1984 was passed. This law included a section related to emergency medical services for children that provided grant funding to support programs related to the expansion and improvement of emergency medical services for children who need treatment for trauma or critical care. The National Association of EMS Physicians was also formed in 1984. In 1988, NHTSA rolled out its statewide EMS Technical Assessment Program to help states measure the effectiveness of their existing and proposed EMS programs. The NHTSA Technical Assessment Program has been updated since its formation in the late 1980s, but still uses the same 10 key components in identifying EMS system strengths, needs, and strategies. These components are the same as those that were included within the EMS category of the 1967 Highway Safety Program Guidelines and are summarized as follows. Regulation and policy. Every state should embody comprehensive enabling legislation, regulations, and operational policies and procedures to provide an effective system of emergency medical and trauma care. Resource management. Every state should establish a central lead agency at the state level to identify, categorize, and coordinate resources necessary for overall system implementation and operation. Human resources and training. Each state should ensure that its EMS system has essential trained persons to perform required tasks. Transportation. Each state should require reliable ambulance transportation, which is critical to an effective EMS system. Facilities. It is imperative that the seriously injured patient be delivered in a timely manner to the closest appropriate facility. Communications. An effective communication system is essential to EMS operations and provides the means by which emergency resources can be accessed, mobilized, managed, and coordinated. Trauma systems. Each state should maintain a fully functional trauma system to provide a high-quality, effective patient care system. Public information and education. Public awareness and education about the EMS system are essential for a high-quality system. Medical direction. Physician involvement in all aspects of the patient care system is critical for effective EMS operation. Lastly, evaluation. Each state should implement a comprehensive evaluation program to effectively assess and improve a statewide EMS system. Additional criteria exist within each of these categories as well. Wisconsin EMS has participated in several of these assessments, with the most recent being in 2012. In 1990, Congress passed the Trauma Care System Planning and Development Act, which added a trauma care section to the existing Public Health Service Act. This act made federal grant funds available to support states in further developing their trauma systems. Among other requirements and provisions, states receiving funding under the act had to adopt standards for the designation of trauma centers. They had to adopt standards for triage, transfer, and transportation policies, and they were required to submit annual data to the Department of Health and Human Services, as well as identifying rural areas that lacked certain emergency medical services. At the federal level, the law also created an advisory council on trauma care systems, along with a national clearinghouse on trauma care and emergency medical services. A year later, in 1991, the Commission on Accreditation of Ambulance Services established standards and benchmarks for ambulance services. In 1993, a formal national multidisciplinary consensus process was utilized to develop the National EMS Education and Practice Blueprint. The purpose of the blueprint was to establish nationally recognized levels of EMS providers, nationally recognized scopes of practice, a framework for future curriculum development projects, and a standardized pathway for states to deal with legal recognition and reciprocity. In 1996, NHTSA published the EMS Agenda for the Future document to provide guiding principles for the continued evolution of EMS, focusing on out-of-facility aspects of the system. Within the EMS Agenda for the Future document, NHTSA focused on 14 EMS attributes that must be considered in planning for the future. When tasked with determining where EMS should be in the future and how to get there, the document summarized key tasks within the 14 attributes as follows. Incorporate health systems within EMS that address the special needs of all segments of the population. Develop collaborative relationships between EMS systems, medical schools, other academic institutions, and private foundations. Address statutory and regulatory barriers and needs to support EMS. Commit local, state, and federal attention and funds to continued EMS infrastructure development. Provide a system for critical incident stress management. Appoint state EMS medical directors. Ensure EMS educational programs are adequate to meet the future needs of the system. Evaluate public education initiatives. Improve the ability of EMS to document injury and illness circumstances. Collaborate with private interests to effect shared purchasing of communication technology. Develop and update geographically integrated and functionally based EMS communications networks. Focus on patient outcomes when evaluating clinical care. Provide feedback to those who generate data within the system. Evaluate effectiveness of EMS using appropriate metrics. These were just a handful of the key tasks identified within the document for moving EMS forward into the future. The document made many additional recommendations related to the 14 EMS attributes that are important to consider in any future initiatives impacting EMS. At the start of the new millennium, NHTSA published the Education Agenda for the Future, a Systems Approach. This document was designed to steer the development of an integrated system of EMS regulation, certification, and licensure. A year after that, in 2001, the National EMS Research Agenda was published to address the fact that, despite EMS existing for about 30 years, existing practices for treating victims of illness and injury were not routinely founded upon principles of evidence-based research. The document sought to elevate the science of EMS and pre-hospital care to the next level by focusing on EMS research. 2001 was also the year in which the National EMS Information System was started to provide a mechanism for national-level EMS data standardization and collection. In 2003, 52 states and territories signed a Memorandum of Understanding drafted by the National Association of State EMS Officials, agreeing to promote and support all EMS data initiatives within their states and to conform to future national dataset definitions. In 2004, the National EMS Core Content was produced to define the domain of out-of-hospital care. Congress determined in 2005 that we needed a mechanism by which to ensure coordination among federal agencies that support local, regional, state, tribal, and territorial EMS and 911 systems. To support these efforts, the Federal Interagency Committee on EMS was established. The federal agencies involved on this committee included the Department of Defense, Department of Health and Human Services, Department of Homeland Security, Federal Communications Commission, and the Department of Transportation. By strategically aligning EMS priorities within these federal departments, the committee hoped to improve the delivery of EMS services while ensuring quality patient care throughout the nation. In 2007, NHTSA published the National EMS Scope of Practice Model as part of its commitment to the EMS Agenda for the Future. The document was designed as part of an integrated, interdependent system that endeavored to maximize efficiency, consistency of instructional quality, and student competence. It is within the National EMS Scope of Practice model that 4 specific levels of EMS licensure were defined as ideal standards across the country: Emergency Medical Responder, Emergency Medical Technician, Advanced EMT, and Paramedic. NHTSA stated that this system of EMS personnel licensure should assist states in developing their scope of practice legislation, rules, and regulations. By following this document, states could increase the consistency of nomenclature and competencies of EMS personnel nationwide, facilitate reciprocity, improve professional mobility, and enhance the name recognition and public understanding of EMS. Also in 2007, the Institute of Medicine published the document Emergency Medical Services at the Crossroads. The purpose of the document was to examine the emergency care system in the United States, explore its strengths, limitations, and future challenges, describe a desired vision for the system, and recommend strategies for achieving that vision. The EMS at the Crossroads document is lengthy and focuses on some very specific topics: the history and current state of EMS at the time, building a 21st century emergency and trauma care system, supporting a high-quality EMS workforce, advancing system infrastructure, preparing for disasters, and optimizing pre-hospital care through research. The committee did recognize several systemic problems, including insufficient coordination, disparities in response times, uncertain quality of care, lack of readiness for disasters, divided professional identity, and a limited evidence base for routine care practices. As we begin to approach the modern day, the National EMS Advisory Council was established in 2007 to provide EMS-related advice and recommendations to NHTSA and the Federal Interagency Committee on EMS. The National EMS Advisory Council provides a forum for the development, consideration, and communication of information from a knowledgeable and independent perspective. It does not exercise program management or regulatory development responsibilities, nor does it make decisions directly affecting the programs on which it provides advice. In 2008, NHTSA released the EMS Workforce for the 21st Century, a National Assessment document, which reported on EMS workforce research regarding whether or not the country will be able to provide an adequate EMS workforce to address the system's needs. Research was conducted on how to attract new workers to the EMS field and retain them across different geographic and population areas. More than 30 years after the first standardized EMT paramedic curriculum was published in 1977, NHTSA produced the National EMS Education Standards document. This document was designed to outline the minimal terminal objectives for entry-level EMS personnel to achieve within the parameters outlined within the National EMS Scope of Practice model. NHTSA also released instructional guidelines documents for the 4 nationally recognized levels of EMS: Emergency Medical Responder, Emergency Medical Technician, Advanced Emergency Medical Technician, and Paramedic. Taken together, along with the National EMS Core Content, National EMS Scope of Practice, National EMS Certification through the NREMT, and National EMS Program Accreditation through the Commission on Accreditation of Allied Health Education Programs and the Committee on Accreditation of Educational Programs for the Emergency Medical Services Professions, these elements were designed to allow diverse implementation methods of the standards to meet local needs and evolving educational practices in a less prescriptive format than the previous curriculum documents, while allowing for ongoing revision of content consistent with scientific evidence and community standards of care. EMS instructors in educational programs would have the freedom to develop their own curricula or use any of the widely available lesson plans and instructional resources provided by various publishers and other entities. Anyone familiar with EMS knows there is no EMS system without an ample supply of EMS providers. Unfortunately, there was no broad national effort to develop, identify, or share best practices in EMS recruitment, retention, health and safety, or other EMS workforce issues, and the urgency of EMS workforce issues has only increased over time. EMS worker shortages, problems with recruitment and retention, declining volunteerism, low worker pay, poor employment benefits, and concerns about worker health and safety issues has raised uncertainty about the viability of the workforce. At the same time, both natural as well as human-made disasters has underscored the vital roles EMS workers play in community health and public safety. In 2011, the EMS Workforce Agenda for the Future followed up on the research conducted just a few years earlier within the EMS Workforce for the 21st Century, a national assessment document, and envisioned a future in which all EMS systems have a sufficient number of well-educated, adequately prepared, and appropriately credentialed EMS workers who are valued, well-compensated, healthy, and safe. The document also identified 4 essential components of a robust EMS workforce: health, safety, and wellness, education and certification, data and research, and workforce planning and development. In 2010, Congress passed the Patient Protection and Affordable Care Act. One of the impacts this law had on EMS was that it provided an incentive for healthcare organizations, hospitals in particular, to work with EMS and other agencies to provide follow-up outpatient care, lest those organizations lose Medicare reimbursements due to readmission of patients for similar ailments within a specific time frame from initial treatment. This provided the impetus for something known as mobile integrated healthcare, also called community EMS or community paramedics. In an effort to provide more efficient and cost-effective outpatient care management, Minnesota in 2011 became the first state to pass landmark legislation in the form of its Community Paramedics Bill to train community paramedics, and Hennepin Technical College in Eden Prairie, Minnesota, graduated their first cohort of 13 community paramedics shortly thereafter in July of 2012. In subsequent years, efforts to fight the nation's opioid epidemic would provide even more urgency for developing community EMS systems that provide more than traditional emergency medical services. As part of NHTSA's efforts to standardize EMS education and credentialing across the nation, the National Registry of EMTs mandated at the start of 2013 that all paramedic candidates must have graduated from a CAHEP/COEMS accredited program. As apparent from the timeline presented within this presentation, EMS has evolved considerably over a relatively short period of time, and only recently have some EMS leaders started to question whether or not EMS is effectively considering and mitigating the risk of harm to EMS personnel, patients, and members of the community in routine activities. These concerns prompted NHTSA to publish the Strategy for a National EMS Culture of Safety document in 2013. By focusing on the 6 core elements of just culture, coordinated support and resources, EMS safety data system, EMS education initiatives, EMS safety standards, and requirements for reporting and investigation, it is hoped that safety considerations and risk awareness will permeate the full spectrum of EMS activities everywhere, every day, by design, attitude, and habit. The intent of the Strategy for a National EMS Culture of Safety document is to change the status quo by creating, encouraging, and supporting a cultural shift that improves the linked domains of responder, patient, and community safety. We previously mentioned the KKK federal ambulance standards that were written in 1974 and had been updated over time through 2007. These standards were effectively replaced in 2013 by the NFPA 1917 Standard for Automotive Ambulances. Updated in 2016, the standard defines minimum requirements for the design, performance, and testing of new automotive ambulances intended for use under emergency conditions to provide medical treatment and transportation of sick or injured people to appropriate medical facilities. In 2014, the National Association of State EMS Officials, with funding from NHTSA, started its EMS Compass initiative to create a process for the continual design, testing, and evaluation of performance measures, in addition to providing guidance for how local systems can use those measures to improve so that EMS can continue to provide the highest quality care to patients and communities in the future. That pretty much wraps up our brief overview of the history of EMS within the United States. Where EMS as a profession goes from here is anyone's guess. With that being said, there are some emerging topics that will probably have significant influence on EMS in the years to come. The first is the aging of the baby boomers and the gray tsunami, in which a high percentage of the nation's workforce will be retiring, while also stressing the nation's healthcare systems. Whether or not EMS will be able to find an ample supply of workers to meet the demand created by pending retirements and increased system utilization is the challenge facing EMS leaders in greater frequency across the country. The opioid epidemic within the United States is also stressing EMS agencies and hospital emergency departments across the country. States have been passing legislation allowing the lay public to obtain and administer Narcan, with some requiring police departments to carry the drug as well. Many EMS agencies have seen call volumes skyrocket due to opioid-related overdoses, and funding mechanisms do not readily accommodate those agencies that find themselves administering Narcan and not transporting patients. The epidemic is also taking a toll on providers who are seeing more overdose victims of all ages and socioeconomic backgrounds and are powerless to effect significant change to reverse the trends. For the first time in our country's history, we have actually seen a decrease in American life expectancy due to the impact of opioid overdose deaths. Some communities are trying to use community EMS, mobile integrated healthcare efforts, to address some of these challenges. How will this growing epidemic continue to impact EMS? Only time will tell. The nation has also had to come to grips with the frequency and likelihood of active assailant incidents in which multiple victims are significantly injured or killed by a single assailant with a weapon of some kind, often a firearm or rifle, within a short period of time. Mass casualty shooting incidents at Columbine High School, Colorado, the Pulse nightclub in Orlando, Florida, Sandy Hook Elementary School in Newton, Connecticut, Virginia Tech in Blacksburg, Virginia, the Aurora, Colorado movie theater shooting, the Las Vegas, Nevada Route 91 Harvest Musical Festival shooting, and others have forced EMS leaders to wonder whether scene safety is a somewhat flexible and nebulous concept, as EMS crews are finding themselves in positions where they must enter an active assailant scene to save lives, even if the assailant has not been apprehended or stopped by law enforcement yet. This has given rise to concepts of rescue task forces and tactical EMS. At some point, we may see training related to these concepts built right into initial EMS education courses. Within the realm of provider safety, health, and wellness, we are also starting to see more emphasis being placed on EMS providers' psychological well-being, and several states have begun codifying presumptions and protections for EMS providers who suffer cumulative or significant critical incident stress injury. As previously mentioned, the NREMT requires all paramedic candidates for NREMT credentialing to have graduated from an accredited paramedic program. It is suspected by many that accreditation will trickle down from the paramedic level to AEMT and EMT education at some point. Lastly, as follow-up to the 1996 EMS Agenda for the Future, NHTSA is developing an EMS Agenda 2050 document that dares to create a bold plan and roadmap for the development of EMS over the next upcoming decades. At the time this presentation was prepared, the EMS Agenda 2050 is going through the public comment period with an anticipated release date of the final document in late 2018. As an EMS professional participating in initial paramedic education, you will arguably have the opportunity to play an active role in where the EMS profession goes in the years to come. Be active within the profession and constantly strive to make the system better for providers, services, the patients we serve, and the public at large. That concludes this module, and you should now be able to describe key historical events that influenced the national development of EMS systems. This presentation was prepared by Waukesha County Technical College in Pewaukee, Wisconsin, and is distributed with an attribution, non-commercial, share-alike 4.0 International Creative Commons license. Copyright 2018, Waukesha County Technical College. For information on WCTC's numerous fire and EMS educational offerings, please visit us online at wctc.edu.